When is a cough effective? A cough is effective when you can generate flows of at least 300 liters per minute. If a cough is ineffective, if you cannot generate that kind of flow, you can assist the cough manually and or mechanically. Now, how do you assist a flow? How do you assist a cough manually? Well, first of all, you have to realize that to cough, you first need to take a deep breath. The average cough is 4 times the average breath. It's almost 2.5 liters of air. Nobody coughs by emptying their lungs and coughing. You don't go, you go, okay. So number one, you got to take a deep breath. Number two, you have to generate a lot of thoracoabdominal pressure by using mostly your abdominal muscles and your internal intercostals. But you've got to hold that pressure with your glottis. In patients with all neuromuscular conditions, except when you have spasticity of the throat, the CoughAssist can prevent pneumonias by creating effective cough when the patient is too weak to do so on their own. And we have published many studies on patients with Duchenne muscular dystrophy, spinal muscular atrophy, showing that their pneumonia rates essentially go down to close to zero once they're old enough to be able to cooperate with the CoughAssist. In the case of spinal muscular atrophy type 1, it's usually by the age of 2.5. Duchenne patients are always able to cooperate with the CoughAssist. So we've been able to eliminate over 100 hospital admissions for respiratory failure and need to clear airway secretions in one study just by using the CoughAssist along with an oximeter at home. And of course, continuous non-invasive ventilation. I've been using the CoughAssist since I was an intern and a resident in 1977. And the patients at that time, many of them had been using it since 1952. So I now have patients who use it every time they get a respiratory tract infection for up to 59 years. You can facilitate the migration of debris by using vibratory techniques and percussion for those divisions. But once you get the mucus up to the 5th or 6th division, you've got to cough it out. No amount of vibration is going to take the place of an assisted cough. The CoughAssist can be used for 2 things. One is for coughing, but the other is for expanding the lungs. Now, not every patient can air stack. And I described what that was. It's getting a volume of air, holding it, take another volume on top of that. If your throat muscles are too weak to air stack, we don't want your lungs to close down and become stiff because you can't fill them with air. So if your vital capacity is 600 milliliters or 500 and it's supposed to be 5,000 and your throat is too weak to stack any volumes of air, now the most you can do is expand your lungs about 10% of them, that's all. So then we have an option. We can use an ambu bag and block the exhalation valve and pump you up with air, or we can use a CoughAssist at a high volume, a high pressure. And that's what we normally do. We'll use the CoughAssist, the inspiratory pressure only, 3 times a day at pressures of 50 or 60 centimeters of water, 10 to 15 times, 3 times a day, to maintain the compliance of the patient's lungs. Well, we've just learned, thanks to the fact that the new CoughAssist has a way to actually measure flows as a function of setting pressures, that my patients with spinal muscular atrophy type 1, and they've been 24-hour respirator dependent since they were 4 months old, none of these people have tracheostomy tubes. But they also have no bulbar muscle function. How do they get secretions out? Well, we have just discovered that they get 7 liters per second of flow, about more than 360 liters a minute of flow, by using the CoughAssist at pressures of 60 centimeters of water. We now have about 15 kids like this over age 15 with SMA type 1, none of them with tracheostomy tubes, all ventilated non-invasively, and all of them depend entirely on the CoughAssist to prevent pneumonias and hospitalizations when they get respiratory tract infections. All children with spinal muscular atrophy types 1 and 2 need a CoughAssist as soon as they're diagnosed. When people are intubated or they have tracheostomy tubes, they need to be suctioned, if for no other reason, because the tube causes airway secretions. But when you suction them, over 90% of the time, according to an article in the Respiratory Journal Chest, you do not get the left mainstem bronchus, which is why over 80% of pneumonias in people with neuromuscular weakness are in the left lung. And that many of our patients who have failed extubations elsewhere have been intubated for up to 5 months, waiting for their insurance to approve their transfer to us so we could extubate them without giving them a tracheostomy tube. During that time, they're being suctioned, and if you turn off the oxygen, you will find that their oxygen saturations are less than 95, in some cases less than 85. I know that because when they come to us, we turn off the oxygen, and their oxygen saturations are rarely 95%. What we do then is we use the CoughAssist every hour through their translaryngeal tubes. And 80 to 90%, within 24 hours, their baseline oxygen saturations will be normal, and they will be ready for us to extubate them. Thanks to the CoughAssist, using it in critical care at pressures of at least 50 to 60 centimeters of water. It is mainly because of the CoughAssist that we have been able to extubate people who have failed extubation elsewhere, now 250 of them. The CoughAssist is essentially non-invasive suctioning that gets both the left and the right airways. It's extremely important in critical care. You essentially always must use pressures that will fully clinically expand the chest in about 2 seconds and fully empty the chest in about 2 seconds. Because if you use low pressures and it takes 5 seconds to expand the chest and another 5 seconds to empty it, then you can only breathe 5 times a minute, because that's 12 seconds, that's 5 breaths a minute, and the patient will get short of breath. So you have to use pressures high enough to clinically fill the lungs with air so that when the chest stops expanding, you then go to the negative pressure. Now, what pressures do that? Usually pressures of 50 to 60 centimeters of water will do the job. And not only will they give you the maximum cough flows, but they will do it in sufficiently little time that the patient doesn't get short of breath from underventilation. Even when patients present with pneumonia and respiratory failure and need to be intubated, we can guarantee that we can extubate them without sticking a tube in their necks, unless they have advanced bulbar ALS. And that, of course, is largely thanks to the CoughAssist and being able to use it aggressively after extubating them to full non-invasive ventilatory support.